go over that tomorrow or Wednesday more in lab, okay? His correction factor is 25, and his target blood glucose is 150, okay? We'll walk through what that looks like more here in a minute, all right? Vital signs every 4 hours, wound care to his left foot, normal saline is 75, and then the diabetic diet. What is different about a diabetic diet?
Carb count.
Yes, we don't put real sugar on this plate, right? So that's one of those things you have to look at whenever, well, and I know that a lot of the times like dietary delivers it, right? But whenever it says diabetic diet on their thing, when dietary delivers it, they won't give them real sugar. They ask for it, like for their strawberries or whatever, they'll give them fake sugar, but they won't give them real sugar, okay? Or for their coffee or whatever. They watch sugar content, watch carbohydrate content of the things that they give to them too. All right. So that afternoon, Mr. Smith complains that he is urinating every 20 minutes. He's really thirsty and hungry, and his vision is blurred. What cues are important in that? Blurred vision? The polys. He's thirsty and he's hungry, or he's thirsty and he's urinating. So what is your priority hypothesis? Hyperglycemia. Okay? Sometimes that, yeah. So what are some other cues that we would ask him about then? About his urine. What about his urine? Yes, the smell, the color, and the
Appearance.
amount. When somebody has polyuria, it is not just like a, oh, I need to go run to the bathroom. It is a, oh my soul, I like pee for 60 seconds kind of a thing. When I used to have, we used to do this training with all of our teachers and stuff. Anybody that had a kid that had diabetes, they had to go through training. And so I had one teacher that called me and she goes, Sandy, I have a problem. I was like, okay, what's up? And she was like, this kid, I think they had diabetes. I was like, okay, why? She's like, because he goes to the bathroom literally every hour. And I got to where I was sending this other student with him because I was afraid he was just going to the bathroom and playing. And she said, after the third time, I said, I want you to count as he's going to the bathroom. And then when you come back, I want you to tell me how long she's like, the kid counted to 45. I was like, okay, yeah. So we called his parent, like, hey, we're just having this concern. Like, these are things we're noticing at school. When was the last time he had a physical? Because he was like 7. So, you don't typically do blood work on a 7-year-old. And his mom was like, I've noticed the same thing. He's tired all the time. He's eating a lot. So she took him to the doctor, and sure enough, the kiddo was diagnosed with type 1 diabetes. Because the teacher was watching. Her big thing was he's out of the classroom all the time because he's peeing all the time. But it was that. So it's a significant amount of urine. It's not just, oh, I need to go kind of a thing. It is like a, I got to go to the bathroom. Can you let me go kind of a thing. Make sense? Okay. Okay, we already talked about that. So with hyperglycemia then, the other actions that we're going to take are, what actions are we going to take for them in this situation? Right, we got to check his blood sugar so we know what it is. What'd you say? Okay, so depending upon what his finger slip blood sugar is, like let's say that it's 450. What are we going to do? We're not going to bring this A1C right now. We're going to give him some insulin. So if we know that we have our correction factor here, we can go ahead and do that, right? So let's walk through that. So if his finger stick blood sugar is 450, then we're going to minus this target number here of 150, okay? To get our 300. And then we're going to divide our 300 by 25, which is how much? 300 divided by 25 is 12, right? So we're going to give you 12 units of insulin. Yes. Rapid or short acting insulin. So this one we're not worried about carb ratio. This one we're just worried about what his target is. Yeah, so this one is 1 unit of insulin to 25 carbs. Does that make sense? So for this test, you need to know about short and acting and regular, or short and rapid acting insulin. Regular insulin is a short acting insulin. You need to know peaks, onsets, and durations. Okay? You don't need to know about any of the other kinds of insulin. There's a couple of different videos that I posted, depending upon your learning style, which one you like better, that can help you. Do not watch the Nurse RN one yet. She does a really good job of, she writes the word insulin and she has all these, like, it's really in-depth, but it kind of is helpful as far as learning and remembering all of those things. So we're going to give him insulin, but what's something else that we need to encourage him to do? If he's laying in the hospital bed, he can't get up and exercise. What's his diet? But in the immediateness, what can we do? What is he complaining about? Excessive thirst. So drink lots of water. Water's gonna do two things for him. What two things you think it's gonna do for him? Right. It's gonna hydrate him and it's gonna help to flush out the glucose. If we're not well hydrated, we're gonna have a harder time getting rid of that glucose. Make sense? Okay. Okay. So the nurse needs to explain insulin therapy. What are the different ways that we can give insulin? Injection. IV. But okay, so thinking back to delivery, the ways that we can deliver it. How does insulin come? Because insulin comes in a vial, but it also comes in a pen. And then another way that you don't see very often because it's not used in a hospital setting is a pump. Okay? So vials and syringes are the most common way that we give insulin in the hospital setting because it's cheaper and you can give it in an IV, you can give it to them sub-Q depending upon the way that it says to be done. At home, a lot of times, then they'll go ahead and use a pen. What's hard about pens is they're all the same color. The label on them is a different color, so then they have to be watchful of that if they're using two different kinds of insulins. What do you think is the benefit of a pen over needles and syringes?
It's easier to.
If you can take it with you, it's easier to take with you. Right, it's easier to set the dose, so you can turn that dial on it. So that's one of those things that is, with our kiddos, we always prefer a pen because a lot of times it's our secretary giving it to them. And if your secretary is answering the phone, because it always happens at lunch, just checking this kid out for lunch, this kid comes off the playground, like, it's just easier on them. But the hard part of it is that they are more expensive and insurance doesn't always pay as good as what they do for vials and syringes. And then a pump is the other way. Pumps have come a long ways since their creation. Pumps are super expensive. They can be like $5,000 to $6,000 even with insurance, depending upon your insurance. Pumps are usually good for 5 years, and usually insurance companies won't buy one other than every 5 years. So if they destroy it for whatever reason, then they're kind of SOL unless they can afford another one or they carry insurance on it. The cool thing about a pump is a pump can give 1/10 of a unit of insulin. So if those whole rounding rules, if they need 12.1 units of insulin, it can deliver 12.1 units of insulin, whereas with a vial and syringe or even with a pen, you can't do that. The other thing is a pump can remember how much insulin you've had and when you've gotten it. We would have kiddos that would come to us like they go to PE at 9:30, mom fed them breakfast at 8:30 and gave them an insulin bolus, and even though their blood sugar was 300, their pump wouldn't deliver any insulin. And so it was a learning curve for me because I'm like, what's wrong? Why did it malfunction? Well, no, the pump just remembered, oh, mom gave us this much insulin an hour ago. The duration of short-acting insulin is 4 to 6 hours, and so we still have insulin on board. We're not going to give them anymore because we could cause them to become hypoglycemic. So those are those things that pumps can do. They're super cool. I'll hang on to that thought here in just a second. Well, actually, let's go there. What is something else that's super common right now for for people that have diabetes, whether it's type 1 or type 2. As a way to, say that louder,
I
Marissa.
don't know what it's called.
Continuous
It's like,
glucose monitor.
Continuous glucose monitors. Continuous glucose monitors have been around for about 15, 20 years, but they've really gained popularity in the last several. Whenever they first started out, they were not very reliable. And so now they've gotten to be much more reliable and they serve a great purpose. What can a continuous glucose monitor do for a patient?
Keeps track of it.
It alerts them when their blood sugar gets either
High or low.
high or low. And then too, a lot of them talk to if they have a pump, a lot of them talk to their pumps. And so then they'll still tell them to check their blood sugar a couple of times a day just to verify, but their reliability is a lot better than what it used to be, because the technology's come a long way. Your book has like a whole section over continuous glucose monitoring. You just need to know about it, but since that is something that is, that's more of a type 1 thing, we're not gonna talk about it this semester, we'll talk about it more next semester. And that's not one of your objectives, is to know about continuous glucose monitors. So just know that, but in the hospital setting, you're probably not gonna see those either, because you're going to be doing finger sticks on those people. They may go ahead and wear them, but you're not gonna be concerned about that. Okay, so some consequences and complications of hyperglycemia. Your patients are at risk for both macrovascular and microvascular disease. And there's a video that I posted that you guys can watch that kind of goes into more depth of that kind of stuff. You can have different nerve damage, and you can also have decreased circulation, which can cause issues with your feet. So it can cause issues with your feet of both neuropathy, but then there's also, did you guys look at all those pictures in your book? What did you notice about the foot? There's a diabetic foot in there. Do you guys know what it's called? It's plump, yeah, and their toes kind of do a weird, and I am, pronunciations are not my thing, okay, y'all? It's C-H-A-R-C-O-T, Charcot foot, something like that, but that's diabetic foot. And that's a common thing in people that their blood sugars have been out of control for a long time. So along with that goes that loss of sensation as well, hypertension, dehydration with falls, poor skin integrity, pressure ulcers, constipation. Why would they be constipated? A couple of reasons. Say it again. Okay, so why would the function of their GI tract be because of the medications, because a lot of the side effects of those medications is GI issues. Perfusion, why perfusion? So think what are our 3 polys again? So what are those 3 polys that would have an issue with constipation?
Water.
Yes, if you're not hydrated, it's harder to go to the bathroom, right? Because your body's going to take away the hydration for your GI tract, and it's going to put it in other places. So if you're not well hydrated, then you're going to have more issues with constipation too. Make sense? Okay, so medications and dehydration. Foot issues, like we said, ulcers, nerve damage. You might also have some retinopathy. What is retinopathy? Issues with the retina and your issues with your eyes. The legal blindness is 25 times more common in somebody with diabetes. They usually don't know that they have retinopathy unless they have different signs and symptoms, which is why a yearly eye appointment is necessary. They get cataracts at a faster rate and at a younger age. When you guys talk about sensory perception, in a couple of units you'll talk more about that too. And they're at greater risk for open-angle glaucoma. And that's there's 2 different types, there's closed angle and open angle, and you'll talk more about that in sensory perception as well. Let's see, nephropathy. What is nephropathy?
Kidneys.
Issues with your kidneys. We've kind of already talked about that. It is the leading cause of kidney disease and end-stage kidney disease. But if you know anybody that works dialysis, 90% of their patients are there because they have type 2 diabetes that's been unresolved. Or, diabetes and hypertension. And most of them have both. Or a lot of them have both. They're in those videos. Yeah. Neuropathy, cardiovascular disease. Why are they at greater risk for cardiovascular disease? Macrovascular problems. People that have a heart attack, they're diabetic, their signs and symptoms are different too. That was, what do we think about? What are the classic signs and symptoms of a heart attack? Chest pain. And that radiates to their shoulder, their left arm, and their neck, and their jaw, right? Somebody that has diabetes, their biggest problem that they'll complain about is that they don't feel good. They're nauseous. So their symptoms are a lot more vague. They don't have that crushing elephant sitting on my chest, shortness of breath feeling. It's more of, I'm nauseous, I just don't feel good kind of thing. Let me see here, what's the other thing? Or the other symptom that they may complain about is that they're extremely fatigued. They can end up with heart failure, both systolic and diastolic heart failure. They're at greater risk for heart failure and fatal cardiac dysrhythmias after an MI. They're at risk for increased risk for cardiovascular accidents or strokes. Women are more often than men have that issue, 2 to 4 times more common in women than in men. Cerebral vascular disease, what does that mean? Anything to do with their head. Dementia is more common in people with type 2 diabetes, and then like I said, CVA also. Okay, what is the nurse's best response to a client newly diagnosed with diabetes who asks why he's always so thirsty? A, the extra glucose in your blood increases the blood sodium level, so it increases your sense of thirst. B, without insulin, glucose is excreted rather than used in the cells, so the loss of glucose directly triggers thirst, especially for sugar drinks. The extra glucose in the blood makes the blood thicker, which then triggers thirst, so that the water that you drink will dilute the blood glucose level. Or D, without insulin, glucose combines with the blood cholesterol, which damages the kidneys, making you feel thirsty even when no water has been lost. C. Those all sound kind of like scientifically, those didn't they? That's why you gotta know, you gotta know. Okay, so now the next morning, our patient now feels, the nurse finds it difficult to arouse Mr. Smith. His skin is cold and clammy, and his heart rate is 110, and his respiratory effort is shallow. Let's go back to black. What would we anticipate is going on with our patient? Hypoglycemia. So with our skin assessment with him, he's cold and clammy. And his pulse rate is 110. I'll maybe have that stuff over here. And his respiratory effort is shallow. So, what actions will we take? Or what are some other cues that we might see from somebody that has hypoglycemia? Confusion, unresponsive, if it's gotten low enough, fast enough, convulsing. Those are considered to be medical emergencies, and we'll talk more about what to do with those here in just a second. What else? Seizures. They'll get confused. Why are they confused? Right, because their brain's not receiving sugar. So they're confused. They can be nauseous. Combative. They act like they're drunk. Is what, like when you look at them, that's what your first suspicion is going to be. And so that's why it's so important for somebody that has diabetes, whether it's type 1 or type 2, to wear a bracelet, have some kind of identification on them, that they are diabetic, so that if they get stopped, then it's not a, are you drunk? It's a, let's check your blood sugar kind of a thing. They can vision issues are the same with hyperglycemia. Their vision is blurry. With hypoglycemia, they may see double. So vision issues are common for both. They may complain about being hungry. Why would they be hungry? Because their sugar's low. Shaky. How many of you guys get shaky and weak whenever you're hungry? Yes. May complain about a headache. What would you anticipate their skin coloring be? Pale. Rapid pulse, rapid shallow respirations, mood change, and drowsiness. In your Iggy book, on page, hang on, I have to look. On page 1368, box 36.1, there are signs and symptoms of hypoglycemia. You do not need to know if they're whatever, or neurogenic. You don't have to know the difference. Just know that those are the signs and symptoms, okay? I'm not gonna ask you all that. I won't get that picky. And then also in your Iggy book on page 1370, table 56.8 is a differentiation between hypo and hyperglycemia, and that's also in your Giddens book. So in your Iggy book, page 1370, table 56.8, and then also look at 1368, box 13, sorry, that should be 63.10, because you don't have chapter 36. 56. Anyways, whatever that chapter is, look at that. It's a box that's 10. Sorry.
56.
Whatever that chapter is. Okay? Tell me that one more time, Taylor. Mm-hmm. 56.10. Okay. So, our blood sugar mnemonic, we talked about this just a minute ago. Hot and dry, sugars high, cold and clammy gives some candy. Okay? So, if they are clammy though, and we're gonna give some candy, we use this as the rules of 15. And so we're gonna give them 15 grams of carbs and we're gonna recheck their blood sugar in 15 minutes. What are some good thoughts about things that are 15 grams of carbs? What are some different foods that we could give?
Fruit snacks.
Starburst, jelly beans, crackers, fruit cocktail, soda. So how much soda are we gonna give? We're gonna give a whole can? Half a can, or one of those small cans of soda? Yes, little containers of orange juice. Orange juice though is contraindicated in somebody that their blood sugar is low. Because what else does orange juice contain a lot of?
Potassium.
Potassium. And so the potassium in there is actually contraindicated. You're gonna see nurses continue to give it because that's what they give, but it's contraindicated because of the potassium that's in it. And you'll learn more about that when you talk about diabetic ketoacidosis. Just know that that's contraindicated. So apple juice is a good one to give. What else? Say that louder. A tablespoon of honey. You said fruit, so half a cup of fruit or a third a cup of juice. And so then what goes along with that, so glucose tablets are another one of those things that you're gonna see people give, and glucose tablets, patients either love them or they hate them. They're kind of big and chalky. Think about like those big giant Smarties that you used to eat like when you were a kid. No, you used to eat them too. But like we get them at Halloween a lot of times, but they're chalky, and so a lot of times they won't eat them. A cup of milk, the carbs in it, yes, but what do you think would be an obstacle to drinking milk, or why would milk maybe not work the fastest? The fat that's in it, and it takes longer for your body to metabolize the fat to get to all the carbohydrates that it has. A tube of glucose gel, we already said half a cup of soda, 15 jelly beans. You mentioned Starburst. My kids at school were all different. I had one little boy that he loved Starburst. But think back, if we know that our signs and symptoms are that they become belligerent or they're hard to reason with, they still Magnolia, those of you who have ever watched it at the beginning, and Shelby, if they're hard to reason with, then you have to give them something that they actually need. So now you can buy Starbursts that are called favorites. You guys ever seen those before? They're my favorites, because I'm not a yellow or orange chick. That's just not mine. I don't like lemon and orange. So I had a mom that would buy the Starburst at Sam's and would pick out the ones that she knew her child would eat, and she would bring those to us. And now they make favorites. Same thing with Skittles. I had a little boy that he would only eat the purple and the red ones. And I think it's like 17 Skittles or something like that. And so his mom would put them in baggies according to how many that he needed to eat. Gummy bears the same way. Something that's not on your list, but that's super common, is those little packages of gummies. You know, like they come like in the Batman or Paw Patrol or whatever. Those are somewhere between 14 and 16 grams of carbs. So a package of those is something that's easy for them to put in their pocket or put in their bag or whatever to have as a quick acting carbohydrate source. So it doesn't really matter as long as it's 15 carbs. But you want it to be simple carbs. Like you don't want it to be a ham sandwich, because while you might have 15 grams of carbs in the bread, and especially if it's whole wheat bread, it's gonna take longer for your body to break that stuff down. So simple carbs. Sometimes you have parents that have a hard time with that. They're like, but wait, we were just talking about nutrition and how that's so important. Yes, it is, but we also need to make sure that they have that quick acting sugar. I had one mom that she made her son carry around a banana, because a banana is about 15 grams of carbs. Only by the end of the day, what do they think that banana looked like? The third grader carried it around all day. It was nasty and it was mushy, and that was usually whenever he would have a harder time and he wouldn't eat the banana because it was nasty and it was mushy. So we had to like, ma'am, I understand that that's what you want him to have, because you want him to have a good snack, but he's not eating it anyways, and we're giving him sugar. So let's just put some banana, because then his books smell like a banana. Have you guys ever done that before? Like put your banana in your lunchbox and everything tastes like a banana? Yeah, he wouldn't eat bananas after that. So you know. There is a box in your book, and let me get that page for you. It's page 1369, box 56.11, for the management of hypoglycemia at home. And it gives a lot of good resources and a lot of good information there. And then hard candy is mentioned in your book. What do you guys think about hard candy for somebody who is hypoglycemic? Choking risk. So it's a choking risk for sure, but then what else about hard candy?
It doesn't absorb as fast.
It takes harder and longer to dissolve. So while it's in your book, you may see that as an influx answer. Common sense or your nursing judgment says not the best thing to use. Okay. We would give at school too, like the Instaglucose is something else that you can give. And it comes in a tube, and you guys may have even seen that some whenever you had a baby that their blood sugar was low, and you guys got to do that. So the other things that we would give is those, you can buy the icing, the riding icing, you know what I'm talking about? We would give that. Where we would keep those for our trainers, for our kiddos that were athletes, because it was easy to give. They could give it through a football mask or whatever. We just wouldn't ever give them black or blue. Why not?
Could be confused.
Trying to look black and blue, and then you can't have are they perfusing well, or is that just stained from them? Yeah. Okay, so you guys talked a while ago about if it's severe hypoglycemia. So if they have a severe case where they are seizing, they become unconscious, or they can't follow your directions to eat or drink, then there's two things you're going to do. What are the two things? What are the two things that you might possibly do? Glucagon or D50. So when would we give glucagon? To patients that don't have an
IV.
If they have an IV, then we're going to give them D50. If they don't have an IV, then we're going to give them glucagon. So what does glucagon do? How does it work? Doesn't pull it out of your muscle tissue, but it pulls it out of this organ, liver. Stimulates your liver to release the glucose that has stored inside it. So it takes about 15 minutes to work. Yeah, I'm sorry. No. So this is a shot, it goes in a muscle. This is not a shot like you're getting like a vegan shot, and you have to mix it together. The needle's not very big. You have to give it in a muscle. You typically don't want to give it in the arm. You typically want to give it in the vastus lateralis or in the glute, okay? Because the ventrogluteal area, because you want it to go to a bigger muscle. All right, so you give that to them, and then you're gonna roll them on their side, because they're gonna vomit. Because their blood sugar goes from really low to really high in the course of 15 minutes, and they're gonna throw up. Okay? And so you don't want, after you give that medication, you don't want to get vomited onto. That's why it's a bad day, right? And so, yeah, we used to always tell our teachers that, like, if you're gonna give it, roll them on their side, because if you give a shot to a kid, that's already hard enough of a day to get thrown up on, you're gonna be like, I'm going home because I'm done with you, right? And so roll them on their side. Then the other thing is to, then the other way is if they have an IV, then you can give them D50. Your book talks a lot more this time around about, this makes about the 5th edition of Iggy, so I always have to compare them all. This book talks a lot more about how that D50 can be caustic to your veins, and it can cause extra desiccation. So be careful whenever you give it, so make sure that you have a good IV access that it flushes before you give that to this medication is one that's carried on a crash cart, so you're gonna give it as fast as you can give it. Tomorrow I'll show you what D50 looks like in lab, and then that way you can see how big that it is, but then also how thick that it is and how hard it is to give. So here's my story with that. I need to keep moving on, but we're gonna tell you my story. So I'm working at my good old little hospital that I worked at, and we had this woman that came in to us. She'd come in on the night shift, and I was working the day shift that day, and she had they found her collapsed in the hallway at Walmart, in the aisle at Walmart. Okay, now this was back when Walmart was open 24/7. This was prior to COVID, right? And so they found her at Walmart in the aisle, and they brought her in, and they did not know what was wrong with her. But like, she was contracted up, like tighter than a ball, like trying to move her arm to do any kind of assessment. And the CAT scan machine happened to be there that day, because it came 2 days a week. So they were gonna do a CAT scan so they could figure out what was wrong with her. No, at our little hospital. They brought her, she was found at Walmart. She was found at Walmart, and they brought her to us. So I go down there to go check on her. I mean, and she is just like, it's hard to do a physical assessment on her. She is tight. And I thought, man, this woman walked into Walmart? Like, what on earth happened? So you had to fill out paperwork before they could get dye. And so whenever I was filling out her paperwork, I was looking at her lab values, and her blood glucose level was 45. And I immediately called my doctor, his clinic happened to be in the hospital that we were in. I was like, I know what's wrong with her. You know, and I was super excited, 22-year-old, okay? Like, I know what's wrong with her. And he was like, great, Sandy, what's wrong with her? And I was like, her blood sugar is 45. And he was like, oh my. And I said, I'm grabbing the Amity 50. He said, grab 2 and I'll meet you there. I was like, okay, so I'm running down the hall, and all my people I'm working with are like, what is she doing now? I was like, I know what's wrong with her. I know what's wrong with her. And they're like, oh my gosh, she's lost her mind. So I go down there and I give her this Amity 50, and she wakes up about 3/4 of the way through it. She's like, who are you and where am I? And so she had taken her insulin with the thought that she was going to go get something to eat out of the refrigerator, because all the kids had been there that day, only they all took the leftovers. So by the time that she realized that she didn't have food in her house, her insulin had already started to work. Because how long does it take? What's the onset of a rapid acting insulin? 15 minutes. Short acting insulin is 30. Okay, so by the time that she realized it, she got herself to Walmart, but she stood there and she literally couldn't share. Her brain was so deprived of glucose by that point in time that she couldn't think about the fact that she needed to open something up and put it in her mouth, chew and swallow. And so she collapsed. But when she got to us, her initial blood glucose level in the emergency room was like 85. And she didn't have any indicator on her that she had diabetes. And so that was something that they didn't even think about. Okay? So, somebody asked me a while ago, so what is our range that we want to know? Because your Iggy book says one thing, and your Giddens book says something else, and even your Iggy book within it contradicts itself as far as what euglycemia is. So euglycemia, or what we want the range to be, is 70 to 140. Okay? So we gave her glucagon, we fed her breakfast, we did some education, we got her a diabetes bracelet, and she went home. Because her whole problem was she was hypoglycemic. That makes sense? So that was one of those, like, I feel really good about myself that I figured that out. Okay, so the nurse is teaching a client with diabetes mellitus who asks, why is it so important to maintain my blood glucose levels no lower than 60 milligrams per deciliter? How would the nurse respond? Glucose is the only fuel used by your body to produce the energy that it needs. Your brain needs a constant supply of glucose because it cannot store it. Without a minimum level of glucose, your body does not make red blood cells, or glucose in the blood prevents the formation of lactic acid and prevents acidosis. B.
B.
Your brain can't store it and can't store glucose.
Use it constantly.
Yes, too high of glucose can cause acidosis. All right, so here's another one for you. A nurse is assessing a client who has diabetes and notices that the client is awake and alert but is shaky, diaphoretic, and weak. 5 minutes after administering half a cup of orange juice, the client's signs and symptoms have not changed. What should the nurse do next? People concerned about potassium. Administer more. And this is one of those questions that I don't really like, because you probably would want to wait 10 more minutes just to make sure, because you don't want to get them from hypoglycemia to hyperglycemia, but, you know, this is one of those questions that was taken from Evolve, so, there we go. Okay, Mr. Smith's blood sugars level out and his sore is beginning to heal. He asked the nurse about the consequences of a low blood glucose level. What should the nurse tell him? So low blood sugar. What would be some consequences of a low blood sugar? The long-term consequences of a low blood sugar. So long-term consequences is if they seize, what would the risk be to them? Fall risk, brain damage, because seizures can cause that, right? Head injuries, brain damage due to the lack of glucose. It's an increased risk for dementia, peripheral neuropathy, so it can be caused by hypoglycemia, migraine, psychosis, and aggression and violence. So lots of different things that can be caused from hypoglycemia, right? So of the two, which one is the greatest concern, hypoglycemia or hyperglycemia? Hypo. We gotta take care of that. It happens fast, we take care of it fast. Hyperglycemia takes a while to get there, it takes us a while to get it back down. When we talk about diabetes, are they hypo or they hyper? Hyper. Make sense? Okay. Hyperinsulinemia is another consequence, or potential consequence. Hyperinsulinemia can contribute to atherosclerosis, that word, can contribute to many different forms of cancer. It can cause elevated triglyceride levels and lowered HDL cholesterol levels. It promotes hypertension because of its role in reducing the elasticity of blood vessels, and this is all in your book. It inhibits the production of glucagon, and then too, like if you take more insulin, then that's part of how it can cause that hyperinsulinemia too. It makes it harder to manage your weight if you have hyperinsulinemia. Okay. So a nurse assesses a client who has a 15-year history of diabetes and notes decreased tactile sensation in both feet. Which action should the nurse take first? C. You always want to examine, you always want to assess. Feet are common locations for neuropathy and injury, so you want to look at them first. People can't always see the bottoms of their feet, especially if they're overweight. You think about those of you who have been 9 months pregnant before, trying to look at your feet or even just put your shoes on. Like, it's really hard to do that. So if you have an issue with if you have a hard time looking at your feet, it's hard to assess them on your own, right? Okay. After teaching a client who has diabetes mellitus with retinopathy, so issues with their eyes, nephropathy, so issues with their kidneys, and peripheral neuropathy, the nurse assesses the client's understanding. Which statement made by the client indicates a correct understanding of the teaching? Say that again. D. Why D? Easier on the muscles, less risk of injury. when we're talking to people about diabetes and we're talking about exercise, we don't want them to do high impact exercises. Why not?
Could cause them to pass out, drop their shit.
And when you lift weights, what's that called? That you can have, what kind of reaction can you have? Starts with a V.
Vegas.
Mhm. And so part of that vagal response, whenever you're bending down and you're lifting and you're grunting, then it can cause an increased interocular pressure. So if we're already at risk for having issues with our eyes, then we can cause that increased ocular pressure as well. It's part of that. The nurse is teaching a client who is diagnosed with diabetes mellitus. Which statement would the nurse include in the client's plan of care to delay the onset of microvascular and macrovascular complications? A. We want to maintain that tight glycemic control to prevent hyperglycemia. Why would you want to limit their fluid intake? Why is that not part of it?
You want to encourage water intake.
Somebody be loud and proud. You don't want to limit fluids, because if they become hyperglycemic and they become thirsty, you want them to be able to flush that out, right? Okay, questions about that question? Okay, Mr. Smith asked if losing some weight would help you. How would you answer?
Yep.
Yes. In your Iggy book, there talks about, hang on, I gotta get the page number. In your Iggy book on page 53, or 1363, box 56.7, there's some benefits to exercise. And some of the benefits are better glucose control. You have, your body becomes more receptive to the insulin, which enhances the cellular intake of glucose, which can cause weight loss. It decreases your risk for cardiovascular disease. It decreases lipid levels. It increases HDL because we want a higher HDL, right? Decreases blood pressure and improves cardiovascular functions. And like I said, we want to avoid the Valsalva maneuver because it can increase your intraocular pressure. You want to avoid any activities that increase your blood pressure, like heavy lifting, rapid head motion, and jarring activities. And decreased pain sensation also can increase that risk of skin breakdown and joint damage. What about feet would be important to telling? Don't wear the same shoes 2 days in a row. He needs to be fit tested for his shoes. Go somewhere like the Red Coyote or somewhere like that where they'll watch them walk and make sure that it fits their feet appropriately. Yes, ma'am. It's all about, you want them to wear different shoes so that they have different pressure points on their feet. Because if they wear this, you think about it, when you wear the same shoes day after day after day, and I'm guilty of this because I wear my Hokas all the time, but after a while, like, my foot will begin to hurt because I put pressure on the same spot on my feet every day. Even though they're good shoes, it still can put that there. And then too, like if their feet get sweaty, then you want to make sure those shoes dry out really well before you wear them again. I just used to buy another pair of shoes. The other thing about that is, what kind of socks do we want them to wear if we're concerned about foot care?
White.
Cotton. What kind of cotton socks? What color cotton socks?
White socks.
That was something the 2 editions ago, Iggy book, it just said cotton socks, but now it says white cotton. Why is white cotton important?
So you can see blood.
Yes, so you can see if there's any blood or discharge, any kind of drainage. So if they're black socks, you're not going to notice that as well, right? So those are some things. Learning foot care and diabetes, you're going to carry that over to some other things that we learned, but there's a whole box about foot care in your book. You also, when you're talking about exercise, you want to be sure that that he warms up and that he cools down well. Why is warming up and cooling down important? Right, prevents injuries. And then what do we want him to do before he exercises, before and after?
Blood sugar.
Check his glucose. You wanna make sure that that glucose is in a good range. Stretching is important too, but check that blood glucose level. You wanna make sure your book, another thing that your book contradicts itself in a couple of places, but you wanna make sure that their blood sugar is between 80 and 250. Now, there's a yellow box that's in your book that students often get caught on, because it talks about type 1 diabetes. We're not talking about type 1 diabetes, we're talking about type 2. So that yellow box, ignore it for the semester, okay? So make sure your blood glucose level is between 80 and 250. And then if they're checking for ketones, if they have ketones, they're not going to exercise because they can cause more harm to their kidneys. And then, let's see. We talked about that already. Okay. Mr. Smith states that he's been Googling type 2 diabetes and wonders if he has metabolic syndrome. What is metabolic syndrome? No, it's a good thought. It's characterized by 4 different things. He's got, I think he has before. High blood pressure, not necessarily BMI, it's waist to hip ratio. High cholesterol, and high glucose or taking blood sugar medications. So this Iggy book, the last edition of Iggy, had like a paragraph or 2 on metabolic syndrome. This Iggy book has a lot more. So if you have an older edition of Iggy, it does not go into as much detail. This one has a chart that like shows what it does, what metabolic syndrome does, and like how it affects things too. So those would be things that I would look at. So those are the 4 hallmarks of metabolic syndrome. The physicians decided that Mr. Smith needs to have surgery to debride his wound. What would you need to do? What medication is contraindicated for the surgery? Metformin. And then we're gonna make him be NPO. So if we make him be NPO and we take away his metformin, what is something that we're gonna need to, what's something we're probably gonna end up giving him? More insulin. Why would we give a short, rapid-acting insulin instead of a longer-acting insulin to somebody that's going into surgery?
Because they're NPO.
You don't want to keep them in the middle of surgery. It's easier to control it if it's a shorter, rapid-acting insulin than it is if it's a longer-acting insulin. Does that make sense?
Yep.
Okay. You want to make sure that their blood glucose level is less than 200. And then during surgery, the anesthesiologist is going to keep their blood sugar between 140 and 180. And they're also going to make sure that they don't experience hypothermia. What would hypothermia do to their blood sugar levels?
Can go hyperglycemic.
It would raise it because they shiver, and it's going to cause their body to release that glucose that stores inside their liver. Okay. You have a client with diabetes mellitus type 2 that has been well controlled with metformin. The client is scheduled for an MRI. What is your priority that the nurse would take at this time? C. You want them to withhold that for 24 hours before the MRI. What is a nurse's best response to a client with type 2 diabetes that's been well controlled with metformin, who asks why now since he's recovering from surgery, that he is receiving insulin therapy for a few days? A. Sometimes because of stress, we just gotta give them a little bit of insulin to get them over the hump. Okay? But they don't change from having type 2